Good afternoon, everyone, and welcome to the Health and Adult Social Care Scrutiny panel. Today, the meeting is online and it is being webcast live. If I can introduce myself and members of the panel, I'm Councillor Habiban Zaman and I'm the chair of the panel. If I can ask Councillor Bill Armour.
Yes, I'm Councillor Bill Armour, Kirk Burton Ward, a member of the panel.
Vivian.
Councillor Vivian Lees Hamilton, Murfield Ward, and panel member.
Fazila.
Councillor Fazila Lunat, panel member.
Okay, David.
Yeah, Dave Rigby, I'm a COPT on the panel.
Okay, and we have apologies from Councillor Afak Rutt, Councillor Leslie Warner, and Lynn Keedy. If we can move on to the agenda, item 1, minutes of the previous meeting. Can we show of hands to say we approve?
Sure.
Any interest?
Nothing at the moment, Chair.
Okay. Item 3, we have admission of the public. We have Councillor Alison Munro with us who would like to ask a question. Alison, would you like to ask your question?
Okay, thank you very much, Habiban. Yes, I recently received an inquiry from a local resident who had been struggling to find an NHS dentist in Kirklees for treatment. He lived, the resident lives in HD5. Obviously, dental health is of huge importance for everyone, and everyone should be given access to dentists to receive treatment via the NHS. So I've been on the Health Watch website and keyed in HD5, and out of a possible 5 dental surgeries, 4 are not taking on NHS dentists, and there was 1 only, but it will only take patients who are referred only. I don't know how you have to be referred. And I then Googled HD8, and there is 1 surgery only in HD8. Again, that's only accepting patients who have been referred. So I'm not sure if this resident has actually been successful in actually finding a dentist, but clearly there's an issue. And I want to know what is being done by the NHS to address this situation, which seems to me to be dire. Thank you.
Thank you for your question, Alison. We will get we'll get a written response out to you because we don't have anyone here this afternoon who can give you a specific answer on your question, if that's okay with you.
Yes, thank you very much, Habiban, and thank you to the committee and the sitting today. Thank you very much, everybody. Goodbye.
Okay, item 4, deputations and petitions.
None received, Chair.
Okay, item 5, question time. We're just putting that, sorry. Item 6 is population health management, and we have Emily Harris here that will present this item with her colleagues. Welcome, Alison. Emily. You're on mute.
It's an excellent start, isn't it? First one of this week, just for the record. Thank you for having us. Thank you for inviting us to come and talk to you today. I'm joined today by my colleagues Steve Brennan and Lucy Wearmouth, and we are working together to progress this agenda. We've got a brief presentation that we intend to talk you through, and you've also had a paper in advance of this meeting which sets out some of the detail here as well. I think it's worth just noting that population health management is about a long-term system-wide approach, and it's about looking at the health and well-being of an entire population. It talks equally to physical and mental health outcomes, and it has a real emphasis on the actions required to reduce the occurrence of ill health. So primary prevention is a really, really important part of population health management. As we go through our presentation, Lucy's going to talk you through some examples of population health management work that we've been doing in Kirklees, but we haven't necessarily called it population health management. And I think there's something about distinguishing between the work that we've been doing and the terminology that now exists around it. There is, and through our presentation as well, we're going to attempt to distinguish between where we mean population health management, which is a way of working to help frontline teams understand the needs of a population, and population health systems, which is really about building relationships and enabling people to work together in a much more structured way. And we'll also make use of some King's Fund work that splits population health management into 4 pillars. So we'll talk you briefly through the wider determinants of health, the impact that healthy behaviours and lifestyles have, places and communities we live in, and the future plans for the integration of the health and care system. So without further ado, Richard or Yolandi, are you going to share the slides? And I will do my best Chris Whitty impression.
Yeah, I think Yolandi was going to help out, but I have a feeling she's just dropped out. She's got on
Okay.
internet problem. Were they sent through?
They were. I've got the slides open. I can share my screen if you'll just bear with me while I do the.
Yeah, I'm happy to do that. Or if you want me to, I can still do it myself if you want, if it's easier.
No, it's fine. Let me have a go.
Okay.
The technology is brilliant when it works and doesn't always do it for you. So just bear with me 1 second. Right. Can you all now see my screen?
Yes.
Yeah. Okay.
Yeah,
so
showing.
take that into a slideshow and put us back to the beginning. There we are. Okay. This does now, however, mean that because I'm sharing my screen, Richard, I can't see any of the panel members. So will you be my hand monitor for me and let me know if anybody's got their hand up?
I will.
Thank you very much. Okay, so I'm going to take the first couple of slides. Steve's going to pick up a couple, and Steve, Lucy, if you can introduce yourselves to the panels when you start your bits of the slides, it'd be good for them to know who you are and where you come from. So we're going to spend some time today talking you through the work that we're doing to develop our Kirklees approach to population health. As I said in the introduction, population health is an approach that aims to improve the physical and mental health outcomes, promote well-being and reduce health inequalities across an entire population. And I think it's really important that we recognise that the parity of esteem there in physical and mental health. And again, as I said, a framework for population health centred on those 4 pillars of wider determinants, healthy behaviours, places and communities we live in, and an integrated health and care system, really recognising that how and where you live your life has the most significant impact on your health and well-being. If you need to see a doctor or if you need to see a dentist, as just highlighted in the previous example, it's really important that those services are available to people and that they are of a good quality, but they only account for a fairly small proportion of your health and well-being. Just to further look into the kind of the definitions of population health management, and we'll share these slides, and you do have the paper, so don't feel that you need to remember this. Population health management is an approach and to improving population health. Its focus is originally around being data driven and using data and intelligence, but actually the population health system that needs to sit around this is almost more important than the data in and of itself, because it's about the relationships, it's about people knowing each other and working together towards outcomes for the population, and being less concerned about the kind of the lanyard that's around the neck, the organisation that they work for, and providing a mechanism for people to work together in a really streamlined way. But if we focus just on population health management for a minute, it includes segmentation and stratification, and really being able to look at our populations to identify those at-risk cohorts and intervene early to prevent ill health. We know that we've got particular populations in Kirklees who are much less likely to present early for healthcare, and we know that that's incredibly important in terms of improving people's outcomes. So being able to use data to identify where we're not seeing people come forward is really important for us. Okay, so these are the 4 pillars that I've referred to a couple of times. Really important that we recognise the wider determinants of health. As I said, how and where you live your life is incredibly important for your health outcomes. We shouldn't underestimate the impact that finance has, that poverty has on people's health and well-being. We know that living in poverty is bad for you. It has a significant impact on your health and well-being. It's been estimated as smoking, and it changes how you behave. It changes the decisions that you're able to take, because you're having to choose between whether you invest in your health and well-being or whether you heat your house or eat a varied diet, for example. We also know that loneliness plays a really significant part in people's health and well-being. So those wider determinants really drive population health management. If we then move on, and Steve's going to pick up and talk about the integrated health system and the places and communities we live in, but if we just move on to talk briefly about healthy behaviours and lifestyle, we still know that smoking is the most significant predictor of poor health for our population. And if we were able to stop people from starting smoking in the first place, or support those people who want to quit smoking, that would have a really significant impact on spend within the NHS and the wider system. So we're really trying within population health management to hold all of these things together and not just have very clinical based pathways that say, OK, so we know about a person now and we can work with them to make them better. It really is trying to take that step back and have an approach that includes earlier intervention. Steve, if I just hand over to you to talk about those other couple of pillars.
Thank you, Emily. So I'll just introduce myself first. So I'm Steve Brennan. I'm the Kirklees Place Programme Director, and that's a role that works across the health and care organisations in Kirklees. So I don't work for any one of the particular organisations, but it's very much a system role, trying to help the organisations and the people in it join up the ways in which they work. So if I just talk through integrated health and care systems and the role they have to play in population health systems. So there's a number of things in here that are kind of critical. So it includes things like making sure we've got integrated service pathways, making sure that wherever we can, we design those pathways in the system around the needs of the individual rather than for the benefit of the organisations who are delivering that care. It's how we work together in various different ways to support people who have multiple conditions, improving things like communication and care coordination, making sure that care records are more easily accessible to the range of professionals who are looking after people, having a real focus around inequalities, and that's something that over the past few months we've been doing some real thinking and some real work on across health and care partners to understand how we've all got a role to play in that, and also making sure that we've got systems in place to ensure quality improvement. So moving beyond quality assurance into ways in which we can actually continually improve the quality of the healthcare that we provide. In terms of places and communities, I think probably intuitively we all understand how important this is, but it's often not always recognised that much in the formal bit of the system. So it includes things like the social relationships that we've all got, the social norms that exist in the areas in which we live, and we know they do differ across the borough. Community networks that are in there, either informal or formal ones, and how as a system we work with those and help support them. The environment, things like air quality and local amenities, they're all equally important in terms of how people can live their lives. If we just move us on to the next slide, please, Emily. We've swapped around. I normally do this for you.
The slides have stopped moving. Just bear with me a second. I said the technology wasn't always brilliant. There we go. So I'll take the first couple of bullet points, and then, oh no, you're the first couple, aren't you? And then it's me. Sorry.
Yeah, no, that's fine. So in terms of population health, it is one of the key strategic aims for integrated care systems. I think when you read the various documents that are out at the moment about how integrated care systems need to work, population health is clearly in there. Sometimes it's specifically mentioned as population health, sometimes it's described in different ways, but they're like a lot of these things, the language changes from time to time, but it's clearly really important in terms of what we need to do going forward. And if you think about some of the changes, they will facilitate greater integrated care and greater joining up of health and care systems. And what we need to do over the next few months and years is make sure that we make the best advantage of those opportunities that might be afforded to us. And I think, Emily, you mentioned this point in your introduction, and it's this way about it's working with frontline teams so that we understand the current health and care needs, and where we can try and predict what local people will need in the future. So a little bit beyond just treating the kind of here and now conditions that people present with, and thinking about how we can help minimise those occurring in the first instance, and where people do suffer from ill health, manage those in ways that prevent it kind of exacerbating as much as we possibly can. Clearly some diseases inevitably follow a certain path, but it's trying to limit that and slow that down as much as we possibly can. And I think the other bit in there that I just would emphasise is it's about helping the people who actually deliver health and care. So yes, you have to organise a system in a way in which does this, but it's not a theoretical exercise. It is there to try and help deliver better care and support to people, and enable the frontline teams to do that. So I'll hand back to you, Emily, if that's okay.
Thanks, Steve. So just to finish off with these last couple of bullet points, really is about tailoring better care and support for individuals, and making the system more joined up. I think it would be really easy to use the data to segment our population on a very disease pathway approach, but what we really want to do is drive conversations and drive relationship building across the range of organisations that make up our system in Kirklees. And the final bullet point about using historical and current data to understand what factors are driving poor outcomes. I think it's really important that we recognise that within data we include people's stories, and we include working with our populations to understand the world from their point of view, because we can sit outside of a situation and say, well, if we just did A, B and C, then we would improve people's health and well-being. But actually, if it's D, E and F that are going to make the difference for that population, because that's what they value and that's what they see as being particularly important, then we'll spend a lot of time and a lot of money doing the wrong thing. And we're really keen to avoid doing that for very obvious reasons. So I'm going to hand over now to just to talk us through some examples of things we have been doing in Kirklees, but also to talk you through about how this links into the existing Kirklees outcomes. Lucy?
Thanks, Emily. So good afternoon, everybody. I'm Lucy. I work in public health, and I'm acting head of improving population health. So, like Emily said, I'm going to talk through some specific examples of population health management within Kirklees, but that haven't specifically been called population health management, just to demonstrate the different levels that we have within Kirklees and the opportunities we have, as well as opportunities for development and learning from that. The first thing we wanted to kind of recognise, which I'm sure you'll all be aware of already, is I suppose the significance of this in relation to the Kirklees outcomes, in that using population health management is one of the ways that we can work towards achieving the Kirklees outcomes. And because of the title population health management, I think people are always drawn towards the health aspect, but it's important to recognise, I think, from a public health perspective, it runs through everything that the local authority and beyond does. So you can use it in a number of these different outcomes, such as being independent or the safe and cohesive outcomes as well. Next slide, please, Emily. Thank you. So I'm going to talk through some examples, and we've tried to relate this to the 4 pillars, the 4 King's Fund pillars that we've talked about. This isn't an exhaustive list of stuff that we're doing in Kirklees. It's just kind of different examples of what has happened. And like I've said, it's all at different stages of development. So the first thing to talk about is a cancer screening pilot, and that was for breast, cervical, and bowel cancer. And that was a partnership between public health, Homes and Neighbourhoods, Wellness, Community Plus, and Pennine Bowel Screening. The first thing about this pilot was using the data to understand which areas had low cancer screening uptake. And by doing that, we could then kind of target resource into those areas. And basically, Homes and Neighbourhoods officers received bespoke training from wellness colleagues and public health colleagues, not just on the clinical aspect of cancer screening, but also in terms of how you have conversations appropriately and sensitively. So it wasn't just about the clinical aspect, it was also about the people. And I think this example kind of demonstrates that that kind of pathway of using the data, but also the importance of relationships and communities in terms of population health management. The next example is about health checks. So you'll already be aware of this, but data showed that there were inequalities in terms of who was accessing health checks. So we knew that we needed to do some work to make sure that the people who really needed to access the health checks were doing that. So this again was a partnership between public health and communities colleagues, and it was about improving access via the wellness service. So again, using local data to identify communities that had poorer health but were also less likely to access health checks. And that data showed us that there are a number of groups, both geographically but other population groups, who kind of fitted into that poorer health, less likely to access health checks. And that included deprived communities, some ethnic minority groups, and people with mental health conditions. And the model was basically the wellness service going into communities rather than expecting communities to go to services to deliver the health checks. And the feedback and the outcomes from that work so far is showing that that kind of using that data to target population groups in that way has been successful in terms of making sure it's the people who really need to access the health checks who are doing that. Next example is about the COVID-19 response, and again, this is a really good example of how we've shared across the system really rich data in order to implement the response to COVID, basically. So the data we used at the beginning of the pandemic to understand which population groups were more at risk in terms of becoming infected with COVID, but also more at risk in terms of poorer health outcomes. And then further down into the pandemic, in terms of identifying which population groups were less likely to have the vaccine. And using that data really has been so important in terms of our response to COVID locally, thinking about the beginning, about the COVID response hubs, through to community champions, vaccination pop-ups, for example, is all because of that rich data that we had. And then finally, this one is about working with the primary care networks. This is actually started off as a pre-COVID example. So back in 2019, public health intelligence colleagues worked with the primary care networks to pull together data packs for each of the new at the time primary care networks, with the purpose of understanding the inequalities that were in existence within each PCN and also what the priority areas should be. And that data included things like demographics, health conditions, health related behaviours and hospital admissions. What we're doing at the minute as well with this piece of work is we're just starting to work again with the clinical directors from the PCNs to get a better understanding of how those data packs have been used, what outcomes have been kind of achieved as a result of that data, and what we need to do differently going forward. Next slide, please, Emily. So this is the last slide from me. This really kind of demonstrates, I suppose, the different areas that are needed to contribute towards population health management. I'm not going to talk through all of this. It's just, I suppose, to re-emphasize the things which feel really important to us. Obviously, the data and intelligence, we need that. That's really important in terms of our understanding, but also we need those collaboration and relationships, those partnerships in place in order to enable that to happen. And as Emily said earlier, it's also really important to understand that it's also about communities, stories and lived experience as well. And then I think it's back to you, Emily.
It is, and I will unmute myself because I can learn by experience. So just to finish off, and then we'll stop sharing the slides and take questions. Really important that we remember the emphasis on collaboration and relationships. And elected members, I think, have a really significant part to play in that. You know your communities well, and you can be a voice for them in many circumstances. A real focus on reducing inequalities via prevention and health improvement. Primary prevention, absolutely central to our approach to improving population health, and also identifying those populations who aren't coming forward so that we can be proactive in engaging with them. We use a term in public health of proportionate universalism, which means that you need to do more in some communities to achieve the same outcomes. That's at the heart of population health management as well. Working with and not doing to, community stories, recognising lived experience, absolutely central. If we just go off and do the things that we think are important, we'll spend a lot of time, energy and money doing the wrong thing. A place-based approach, and again, going to a fairly granular level with communities. And then we're working at the moment to reconnect the work we've been doing in Kirklees back up to the West Yorkshire Integrated Care Partnership. Some of that work had started to happen prior to COVID and then stopped a couple of years ago. So that's just kind of restarting, and we will be re-engaging in that. And then we've also recently taken a version of this presentation to the Kirklees Health and Care Partnership, so engaging with a whole range of chief execs and senior staff from the organisations that make up Kirklees, so that we're all on the same page. So that's the end of our presentation. I'm going to stop sharing my screen now because that then means I can see you all. And Councillor Zaman, if people have questions or observations.
Thank you for that presentation, Emily and the team. Yes, we do have questions, and Dave's got his hand up. If we can ask Dave to ask his question.
Hi, thanks for the presentation. What is population health management? The first sentence of that says defining population health management is challenging. I'm glad you said that because I think it is quite a challenge to get your head around it. However, I guess that in order to make progress, you have to prioritise. So my first question is, how do you prioritise in terms of setting up local specific initiatives? And the second question is just looking at those examples that Lucy went through. The first two, the cancer screening pilot and the health checks, it would be interesting to know what feedback you've had in terms of outcomes from that. You've described what you've done, and Lucy did mention there had been some feedback, but it'd be useful for us to hear how effective those interventions have been. Thank you.
Okay, so shall I start answering, and then Steve, Lucy, if there's anything that you want to add. Dave, your first question about how you prioritise, obviously absolutely vital. The priority for us is the relationships and people working together across the system, so that they know each other, so that they can use the data to make those decisions. I suppose at the heart of your question was also possibly a slightly more clinical question about how do you identify those priorities. That is really challenging because there are all sorts of things that we could do to improve the health and well-being of our population. But I think if we take the approach of really focusing on building relationships across the system so that people can work together, then we can start anywhere, and anything that we do that improves people's ability to identify their symptoms early, to present early, and therefore for us to intervene early, will have a positive outcome on their health and well-being. I also think recognising that how and where you live your life, the quality of your housing, the quality of the green space that you have available to you, and the impact that that has on your health and well-being is really important, rather than just immediately going down a very clinical pathway.
Yeah, just thinking about, to take a practical example of the cancer screening. How did that come about? Whose idea was it, and how did it get implemented?
So again, I'll start, and then Lucy, if there's anything that you want to add. We've had a history of working on cancer screening in Kirklees. We've done some really important work with places like the Eden Project over the years to work with Muslim women to increase their likelihood of engaging in cancer screening. And on the back of that, and working with colleagues who have experience in that area, we also identified and recognised that there were a significant number of people who were living in our social housing provided at that point by Kirklees neighbourhood housing, who weren't engaging in cancer screening. They weren't coming forward early, either because they didn't recognise the early signs and symptoms, or they didn't value the importance of a screening approach. And we know that our housing officers have particular inreach into those communities. They spend time in those communities, they build relationships, and they know people. Recognising all of those things, we identified that giving some additional training to those housing officers so that they could make every contact count and have really good, well-rounded conversations with people about the importance of screening and how to access it was what triggered the work. In terms of the impact that it's had, it's allowed us to have those conversations in a slightly different way, starting from where people are at. And there's something very different about having a conversation with somebody in their own kitchen, rather than it requiring them to go into a clinical setting to have that conversation. And the early feedback that we're getting from that work is that it is helping people who wouldn't have otherwise engaged in screening, be that cervical screening or breast screening or bowel screening, to engage in it. So the housing officers have been able to direct people to how to access bowel screening kits, for example. And it's early. We haven't been doing it for very long, but the early feedback that we're getting is that it is enabling people who would not otherwise have engaged in screening to do that. And we know, particularly for bowel cancer screening, actually, the earlier that we identify people with the signs and symptoms of bowel cancer, the more likely they are to have a positive outcome for their treatment. So it's good so far, I think, is my summary, Dave.
Thank you. That's helpful to have that sort of practical example.
Lucy, is there anything I've missed?
No, I don't think so. That's great.
Okay. Thank you.
Thank you for that response. Councillor Fazila Luna, do you want to ask your question?
Thank you. Thank you once again for your presentation. Part of my question, Dave has kindly covered. And I'll just still make the comment in regards to the population health management. It is quite confusing, but just to kind of pick up on what you said earlier, Emily, as well, is for those that are not coming forward and presenting themselves to the health services, anything as elected members that we can do further, I think all elected members would be happy to help. One thing does concern me a little bit is about the officer training, the housing officer training. In which capacity is it? Just a simple signposting towards the health, whether it's the checks that you are recommending them? Is that what you're doing in terms of training? Sorry, it's a very cheeky first question. Is that what you're looking at?
To be perfectly honest, Councillor Luna, I haven't been involved in the delivery of the training, so I wouldn't want to comment too much on what the actual content of the training was, because I might be telling you something that isn't true. I can get you some more detail on that. On my very basic understanding of what the training was, it was how to support those housing officers to help people have kind of health seeking type conversations, to understand that I think sometimes people think screening is something that you have once you have a disease, and therefore it tells you what the treatment for that disease should be. Lots of people don't want to take up the time of health services if they are feeling otherwise well, but that's absolutely the point of screening, is to undertake those tests pre anybody having any kind of symptoms. But we can get you some more detail, or in fact Lucy might have some more detail as to what the content of that training was. Again, I think it's worth emphasising that this is the start of something, and we will keep going, and the training that's delivered will become more complex, more nuanced as we go along, because we're learning as we go.
Thank you.
Have you got something more useful to tell Councillor Luna?
No, that was fine. Yeah, I agree with you about it being like the start. I think we're bringing these, we're not bringing these examples as like finished kind of products, but as a start of something, and it's really useful to get your feedback. The other thing I was going to add about the cancer screening stuff, which I didn't say, was the third element of this was about the community element. So they also work, for example, with local mosques in order to work with local communities. So it was that thing about kind of working with, not doing two, rather than just officers going into a community and then kind of leaving again. In terms of the training, it was a joint kind of collaboration between, let me just check my notes, between wellness and public health and the penine bowel screening. So it was a kind of a combination of that kind of the expert clinical stuff, but also the skills around having the conversations in a sensitive and appropriate way. And it's not just about having a conversation with every single person that you meet, but kind of understanding the appropriateness of the situation that you're in and having those conversations when it's appropriate. If that makes sense.
It does, and I think that the reason I asked the question was about the officers, whether and I'm assuming they would be getting the support in terms of mental health for themselves as well, because obviously when they're going through the screening, perhaps for a resident or a family, it could obviously cause implications on their own mental health. Yeah. So that additional support there. So I don't need an answer for that, but I do appreciate what you've said. Just if I may continue, Chair, just another question in regards to multiple conditions. So if they were to present with multiple conditions, it's quite confusing into which pathway they need to go to, and often what we do see is that they get passed from one pillar to post, and which is why they sometimes slip through the net until a very later stage. So trying to see if we can identify stages of where we can work with people with multiple conditions. Thank you.
I think it's really important that we recognise that this is about people working with residents to increase their awareness and understanding of the importance of screening. This isn't a clinical service, and if somebody had clinical needs that meant that they needed a medical intervention, then the first port of call for that would be the GP and primary care, and any onward referrals that would be made into secondary care would come through that route. So I think that's probably the first point. Absolutely, we recognise that people have complex health needs, and increasingly in our populations, it's multi-morbidity, so multi-illnesses that are causing people and the ongoing problems as opposed to earlier deaths. So absolutely recognise that people have very complex health needs, and for some people that might mean that they have multiple contacts with health services on a fairly regular basis. So part of population health management is also working with people like the acute trusts to say to them, hang on a minute, if you've got somebody who's coming for an ophthalmology appointment and they, by the very nature of their needs, can't drive because they can't see very well, don't give them an appointment for 9 o'clock on a Monday morning if the bus service doesn't start running until 10. It's really starting to look at the world through that lens and to be practical and pragmatic. I was reading an example the other day of a lady who has, she has 4 or 5 complex health needs, and as a consequence of those has upwards of 20 hospital appointments a month. So what can we do practically to say, all right, well, let's try and cluster those appointments so they're all on a Monday, so she doesn't have to come Monday, Tuesday, Wednesday, Thursday, Friday, and it doesn't take over her whole life. So we're working towards those approaches as well.
Thank you.
Thank you, Emily. Councillor Liz May, do you want to ask your question?
Thank you. I'm a little bit confused, which I know you know is an easy thing to do with me.
I can't possibly comment.
Very good answer. The breast, cervical and bowel screening pilot uses the past tense in your report. So can you answer, is the pilot still running or has it finished? And the health checks, I'm presuming they are still running because that's in the corporate plan for the next couple of years. So I'm presuming that's there. But in an integrated health and care system, you gave data packs in 2019 to the primary care network. Are you planning to give updated data packs, and what will they cover and when? And then you talk about not having a separate work stream for PHM, and therefore I'm wondering what work will be done in this area to work towards reducing the health inequalities.
Okay, Councillor Smage. So I think you asked 4 questions in that. So I'm going to take them in a slightly random order because I was scribbling them down as you were asking them. So if I start with the data packs, yeah, absolutely. Those data packs were issued to the emerging and very kind of young PCNs in 2019. We are now working again with the clinical directors of the 9 primary care networks to go, all right, so we gave you a thing. Was it any good? Did you use it? Did it help you? And as we refresh those data packs, what do you need them to look like in order for you to further your work? Recognising that in the 2 years since we issued those data packs, the primary care networks have actually developed and matured quite significantly. There's still some way to go. I wouldn't say that they are fully mature and finished, but they've made a lot of progress. So yes, we are working with them to look at the data packs. We've also been working with them and have public health officers who are part of those primary care networks on a regular basis. So it isn't just that we go in and do a thing for them and give them a product. There is that developing relationship. So yes, for one of your points, data packs, yes, absolutely. We are working with them to look at what they need them to look like. One of your other questions was about the health. Well, your observation was about the health checks, and yes, they are ongoing. It's in the, as you know, it's in the council plan, and we'll continue to pilot that work. Really keen that what we do is take those health checks into communities and take them to where people are anyway, so that it doesn't have to be an additional thing that you have to go. We know that some barriers, they might seem very small from where we're sitting, but actually they can be fairly insurmountable for our populations. One of your other points was about the tents in the report about the screening. The initial work has happened. We're currently learning from that initial work, and I'm fairly confident that it will continue again because it was good. They were good quality conversations, and it had good impact in our population. And then your last point, or the point that I'm going to get to of yours last, around the work stream and the approach. What we're really trying to do with this work is not say, and this is population health management, it's different and special and sits in an isolated way. We're trying to say, actually, because it's so important and it covers so much of what everybody else is doing, we want to weave it through. So we're not having a specific work stream for it because we don't want to bring people into a separate room and talk about it specifically. We want to weave it through. So no, there won't be a particular work stream, but Lucy has a role as the acting head of improving population health. Steve and I spend lots of time together talking about these things in various forums. So there won't be a particular work stream, but it will be an important thing that we talk about with people on a regular basis. As I said in the presentation, we've already taken it into the partnership arena and had those initial conversations there. There is absolutely a commitment to doing this at a Kirklees level. It will form a really important part of the systems leadership work that Steve and I are reinvigorating at the moment, to work with people to help them understand how we work towards outcomes rather than outputs. A lot of that sounds quite kind of amorphous at the moment, and it would be really easy to go, okay, so what we need is a work stream, and we need an action plan, and we need a Gantt chart that will tell us what progress we're making. We're trying very hard not to do that because we'll go where the energy is. And as I said, I think it was in my answer to Dave, we can start anywhere and do something in this arena, and it will have an impact, a positive impact on the health and well-being of the population. And you are a voice in my head a lot of the time in this work, Councillor Smage, because I know that you talk very passionately about the need for people with complex health needs to not have, you can have a complex health need and not have a complicated response to it by the system. And that's what we're really trying to do here as well, is smooth a lot of that stuff out so that it makes people's lives easier.
Yeah, thanks. I'm just concerned that, I know you don't want another work stream, and I'm not advocating that you have another work stream. I'm just concerned that how this work will actually make a difference to the health inequalities in a practical way. That is my concern, and that is not what I'm seeing at the moment. You know, it's just discussions at the minute. I'm not seeing, from what you've said, I'm not getting that feeling of this is practically how we're going to make a difference in the future, because it is a long-term thing, isn't it? Yeah, it is. It definitely is a long-term thing. And I was concerned about your screening pilot, that it wasn't just a pilot that had happened, that it is something that carries on, because I mean, you know, when you look at the Kirklees Observatory data, it is for 2016, 2018. It's not up to date at all.
It's not.
So it is going to be, it may be considerably different, you know, and therefore I think things like the screening will have even more importance now, which is what concerned me about the past tense that was used in your report. Yes,
that might be a grammatical issue as much as anything, Councillor Smage, so we can edit that. But I think you're absolutely right. This needs to be a practical programme of work that makes a difference to the health and well-being of the population of Kirklees. You're absolutely right in terms of screening being important and getting people to come forward for those screening opportunities that they perhaps haven't taken up during COVID. That needs to be an area of focus. In terms of the screening pilot, as I said, we're learning from it. We know that there have been some really good things that have happened through it, so let's learn from that and do the things that have worked going forward. We're at the start. we're at the start. We have huge ambition. We have been able to give you some practical examples of things that have already happened in the examples that Lucy gave around the health checks, around the screening, and around the vaccination programme. And actually, I think that's been an incredibly useful practical example of how, when we come together with a single vision and a single data set, we can have really not just have good conversations, but have good conversations that turn into action to say, OK, so we've noticed that this population in this place are not coming forward as rapidly for the vaccination as maybe we would have liked them to do. So we'll take a thing to them. We'll put a pop-up in that community. And we know that by doing that, we've enabled people who wouldn't have otherwise taken the vaccine to have it. So it is a practical tool. And we will absolutely be able to measure the impact of the work that we do. I promise.
Yeah, it's just that, you know, from what you're saying, we're not seeing sort of like in 5 or 10 years time, this is where, you know what I mean? This is where we would like to be. And I just, you know, the milestones and where we would like to be and how we would like to improve health inequalities is something that I think is really, really important. And yes, okay, it's not a separate, but this is what we did. This is what we need to do. It is the bit that's missing for me, but I'll shut up now because I've taken enough time. Thank you.
Thank you, Councillor Smage. I agree with that. Sean,
I don't disagree with it.
Sean, thank you for waiting patiently. Can we ask you to speak about the air quality?
Yeah, thank you, Chair. So obviously I was asked to come today just to give a quick overview and a verbal update on air quality in Kirklees. And obviously for many of you, you will think of air quality as an environmental indicator and something we monitor for environmental benefits. But fundamentally, air quality has a direct link to public health, because obviously the air quality that we monitor is effectively monitoring pollution or pollutant sources that are directly impacting the health of our residents and our across Kirklees. So just to give a bit of regulatory background, in terms of legislation, the Environment Act 1995 places a legal requirement on local authorities to write reports for government, to declare air quality management areas or areas which have exceeded the air quality objectives, to create a 5-year action plan, and to submit annual air quality status reports to DEFRA. So the annual report that we submit to DEFRA each year is uploaded to our website, along with our 5-year action plan and strategy. And this document, along with the annual status report, effectively outlines what our actions are in terms of combating or improving air quality, but also the annual status report reports on what our monitoring results were for the year. And that happens every year, and we upload that every year to our website once DEFRA ratifies that. There are also other acts and regulations which set air quality limit values and define regulatory and statutory requirements related to air quality or other air quality matters, such as smoky chimneys. And in terms of the legislation, it does place a legally binding limit for concentration of outdoor air pollutants that affect public health, and these are focused on particulate matter, or PM10 and 2.5, along with nitrogen dioxide. The primary pollutant within Kirklees that we monitor is nitrogen dioxide, or NO2, and this pollutant is always linked to transport emissions, which is why we monitor in roadside locations and in areas where there are it's near to busy roads, where it's congested. And obviously the air quality objective set for NO2 is 40 micrograms per cubic meter. So that is our target effectively, and our monitoring assesses compliance with that target, and we therefore report on that annually to say whether or not an area is exceeding that target, and therefore is an AQMA or should be declared an AQMA, an air quality management area, or if it's beneath that 40 microgram target for nitrogen dioxide, we basically understand that it's not exceeding that air quality objective. It doesn't mean that there isn't air quality issues there. I think if it's beneath that air quality objective, we feel it's compliant, it's okay, but there's always work that we're doing to continue to improve air quality. So as I touched on just before, in terms of monitoring, we do undertake monitoring across the entire district. These are primarily, as I say, focusing on transport emissions, so they are where areas are congested. But obviously, we do undertake air quality monitoring in those AQMAs. The monitoring focuses on the impact of air quality emissions on the health of residents. So we take samples from representative locations near houses and on sort of street lamps and those sorts of things, and we don't install monitoring equipment directly at the curbside, directly at a tailpipe, so to speak, because it has a sort of dilution factor the further you get away from that roadside. And for a property, they're not built directly on the road, so there's always a what we call a distance attenuation. So all of these calculations go into our report. It's not as simple as getting a result and that's the number we report. We have to do these distance calculations and understand exactly what that means and what that translates to. In terms of the specific air quality monitoring function, we have diffusion tubes, which are the most common method that we monitor air quality across the district. These are cheap and easily transported across the district and are basically located on street lamps and locations across the district. So they are, as I say, we've got 87 of those across Kirklees, and as well as that, we also have fixed air quality stations. We have 2 of these located at Bradley and Ainley Top. And we also have 5 Zephyr sensors, which are multiple emission monitors, which monitor both particulate and nitrogen dioxide. And these are being deployed across differing locations to either co-locate or compare results with the diffusion tubes and these Zephyrs, so we can confirm analysis of those results, or we're looking at, because they're portable, we're looking at deploying those Zephyr sensors at locations such as schools, so we can combine that with public health activities such as Scoot to School, so we can monitor sort of baseline emissions before, pre and post drop-off time, so to speak, and that's the function of those portable monitors. So in terms of air quality management areas, we have a total of 9 across Kirklees. These are located at Thornton Lodge, Huddersfield Town Centre, which is everywhere inside the ring road, Outlane, Liversedge, Edgerton, Birkenshaw, Ainley Top, Bradley, which is the Leeds Road intersection, and at Eastborough. Within these AQMAs, there are residential properties which are likely to be affected by air quality impacts, and so this is part of the reason why an air quality management has been declared, because there is a level above the air quality objective, and we are therefore targeting air quality actions in these locations. So in terms of those specific AQMAs and in terms of the residential properties within them, we basically have looked at how many residents reside within them, and so for Thornton Lodge we have 30 residential properties. For Huddersfield Town Centre, we have 1,400 residential properties. For Outlane, we've got 12. For Liversedge, we've got 9. For Edgerton, we've got 7. For Birkenshaw, we have 51. Ainley Top, we have 41 properties. Bradley, we've got 2. And Eastborough, we have 75 properties and a school. So depending on the size of that AQMA, you can tell that the larger number of residential properties, the bigger that AQMA will be. The smaller that AQMA, the obvious focus where those properties may be affected by the proximity to that intersection or to that congested area. So if there is a larger area, for example, Huddersfield Town Centre, the ring road and everywhere inside the ring road is going to contain lots more properties and therefore have a lot more sensitive receptors, so to speak. So when we consider the residential properties within these AQMAs and the potential impact to their health as a result of poor air quality, we are acutely aware of links between poor air quality and inequalities and poor health, including for those in high-risk groups and vulnerable populations. This can include exacerbating asthma, respiratory illnesses, heart disease, and reduced life expectancy. So these are some of the known links of air quality impact to public health. But we obviously are aware from publicity of other relevant impacts, like in London, where air quality has been linked or attributed to a recent death. Thankfully, we don't have the level of air quality like in that location where there was a death reported and linked to air quality. But obviously, we are working extremely hard to make sure that never is the case. But in terms of sort of detailed quantitative information on the direct air quality impacts on the health of our residents, this data is not that clear. So we obviously report on air quality within locations, but we don't understand the detailed sort of links between air quality and health impacts, so to speak. So they can be linked to other illnesses and other causes. So there's probably not a clear direct link, but obviously we work closely with public health colleagues on these considerations and continue to be involved in local air quality partnership working groups, transport and health groups, which have public health colleagues present at those meetings, and we work with colleagues all across West Yorkshire. One last thing in terms of future considerations before I finish is the recent introduction of the Environment Act. Moving forward, changes announced within the Environment Act will mean we will probably face more challenging air quality objectives, which will probably be set at a lower level than they currently are. These chart changes are not yet announced by the Secretary of State, but will be, and they will be consulted on, but will potentially, and I say potentially because we don't know what this looks like yet, it may potentially have an impact on our current compliance in future years. And obviously that's not a negative thing if stricter air quality objectives are set. This means we're going to be aiming for better air quality for our residents across Kirklees, but this will likely mean if more stringent air quality objectives are set, we're probably going to have to declare more air quality management areas. And in terms of it being a Kirklees specific focus, this probably won't be. This will be across the country, locations where stricter air quality objectives will mean more need for intervention, more need for targeted actions, and most likely more need for funding in order to continue to monitor and to take radical action to improve air quality across the district and the country. But obviously we're aware of changes to vehicles in the future. We appreciate the electric vehicle revolution will help to combat some of these vehicle-related emissions, and we continue to take steps ourselves to either improve air quality through the introduction of electric vehicle infrastructure, through school engagement activities, through promotion of modal shift, by working with active travel colleagues as well as public health colleagues, and by supporting the other campaigns such as Scoot to School, as I mentioned, but also anti-idling awareness activities, and continuing to look at sort of opportunities for enforcement where it's deemed appropriate. So I hope that gives a bit of an overview. I'm not sure exactly what was hopeful, but by all means, if you've got any specific questions, I'm happy to answer them. Thank you, Chair.
Thank you for that, Sean. Liz, are you wanting to ask a question? Because we are running out of time and officers do need to leave, and we've also got the next speaker waiting.
Oh, sorry. I just had a really quick question, actually. The feedback, I won't mention the lack of progress at Berkhamsted Roundabout, but the feedback on the on the report says that the public health outcomes frameworks was not mentioned in your report, and I just wonder if you were going to change that in future reports. It was just a really quick question for a really quick answer.
Yeah.
Thank you.
So thanks, Councillor Smage. I think any feedback we get from DEFRA, if we were to not consider that or take that on board, I think it'd be an oversight. So by all means, that will definitely be something that we consider and implement within future reports. I think on the Birkenshaw roundabout project, I will say
okay. That's a separate conversation. Okay. All right. That's a separate conversation.
It's beyond me. I will defend myself.
Yeah.
It's beyond.
Yeah, that's a separate conversation. But it was just the public health outcomes framework.
At a future meeting. Is that okay?
Yeah, by all means. Thank you.
Okay. I want to move on to the recommendations now. Thank you to the officers for having that detailed input and the presentations you've provided us with this afternoon. I recommend that we receive the report and recognise the opportunities for learning and development as outlined in the report. I suggest you come back to us at a future meeting with some data around the impact. I also recognise that there's crossover between this panel and the Economy Neighbourhood Scrutiny panel, but this was sort of information, the information given has been noted. Thank you. You may leave and we will move on to the next item, which is, Kirklees Safeguarding Adults Board 2020-2021. And we have Jackie Stansfield, who will be speaking on this report. Is that right, Jackie?
Rob McCullough Graham, he's our new independent chair. He's joined the meeting. Thank you.
Okay.
Thanks very much.
Up to you.
Thanks very much, Chair, and thanks, Jackie, for that. Jackie's here for any difficult questions. I just want to put that up front, okay? Thanks very much for the opportunity of introducing this annual report to you. So the Safeguarding Board, of which I'm now the new independent chair, almost 3 now, and we have 3 major functions within that. One is to do their strategic plan, one is to report on that strategic plan, and the other is to undertake any safeguarding adult reviews if any of those arrive, and we've had a couple recently that we've just published within there. Obviously the work of the board is much wider than that, and it's across the whole of the partnership. I just wanted to give some thanks actually to this report to my predecessor, Mike Evans, who you'll see is given the introduction to the report. And I really echo just about everything that Mike has said in the report, and in his thanks for the staff who've actually supported the board, so Jackie and her other staff members around there that have supported it, but also the breadth of the membership. Now, I've worked with safeguarding boards virtually throughout all of my career, usually attending them and being held to account by them, not as a chair. But I have to say that the work that's been undertaken by Mike and others to set it in Kirklees and its operations, I think is second to none. So I'm giving this panel some assurance that what I've witnessed over the last 12 months, or nearly 12 months, is that we have systems in place in Kirklees which are monitoring safeguarding effectively and reporting on it and continually improving, because we're never going to get it 100% right. There's always going to be incidents that we have to address, and there's always going to be issues, and it's a changing agenda constantly within there. But what I would like to give some assurance, and I think the report does this, is that we have the people systems in place and a culture in Kirklees which is open to inquiry, it's open to investigation, and it's a very curious board who actually want to do the best for that. So I think that's all the introduction I want to give, and could hand over to any questions that I of course will bat straight to Jackie if I can't answer them. But thank you, Chair. Thank
you, Rob. Over to the panel for questions. Dave.
Hi, thank you. Good afternoon. I've got 2 or 3 questions. They're on page 24 of your report, which is page 54 of our pack, and it's on the agency achievements, the first page of that. First of all, there seem to be quite a few references to self-neglect in the report, and I'm not sure if that's been the case previously. So I'm gathering that that's probably a rising issue as far as safeguarding is concerned. Secondly, the reference to the COVID-19 response. I just wonder whether there are any specific COVID-related safeguarding issues that you'd like to highlight that have arisen over the last couple of years. And thirdly, on deprivation of liberty, there's a reference to liberty protection safeguarding, which is due this year, and I just wonder what that was.
Do you want me to answer,
Okay.
Rob?
I'll have a go.
Okay.
All right. So self-neglect is a real priority for the board, and we introduced a self-neglect toolkit to help agencies actually respond to it. In fact, our two latest reviews that we did around safeguarding adult reviews involved self-neglect in both of them, which is a particularly difficult issue to address, hence the reason we toolkit. That not just in local reviews that we undertake, but nationally as well. Issues coming to the fore, and I think it's particularly challenging for services to actually get involved within there. It really has to be a partnership response to self-neglect, because for a lot of these cases, one agency might have identified it with an individual, or they've presented to one particular agency, but it requires a response and an ongoing response from lots of different agencies within that. Hence, an important issue for the board within there. One of the other things which accompanies that is that for a lot of self-neglect, if an agency can't get access or can't get a response or can't engage well with the individual, one of the dangers, and this has come out in the reviews, is that that individual is left and there's not a transference onto another agency or another methodology of actually doing that engagement. And that's something that the toolkit and our work is actually trying to focus on, so that we don't let these individuals go. There's some other imaginative way to get the engagement so that they can start to respond to the supports that are available for them. And that's just the nature of self-neglect. So it is important for us. There's been an increase in the numbers of cases around that, but partly that's because we're much more aware of it. And that's we've gotten the reporting for it. And the COVID-19 issues, I see there's some other service heads and service directors here. They may be able to answer more directly than I can. But talking to each of the different services and in my own experience, seriously, I think a lot of the impact from COVID-19 is going to be long-lasting. We've seen through the isolation of individuals, through the inability to actually get access to some of the services, is going to have a long-lasting effect, and we need to be aware of that. I think some of our own services have faced challenges because their staff teams and resources have been strained, either through absences or just the demand that's been placed on those services. And we're not seeing that abate at the rate that we would hope that. So I think COVID-19 is going to be with us, and the ramifications of that for quite some time to go. We've done quite a lot of reviews across the country as to what that impact has been and how we've addressed it. A lot of lessons have been learned, but I think some of the benefits that have come out, if I can just mention them, it really has forged some of the partnership working much better. I think our health colleagues and our council colleagues we're always working closely and joined at the hip, but now actually sometimes you can't tell a difference and are looking at shared resources now, shared budgets, and a shared endeavour between them that I don't think existed before. So there is some silver lining to the COVID-19 within there. My worry as chair of safeguarding is that for some individuals that and particularly around mental health issues within that, may have lost access to some of that support, or may not have been presenting as much as they should have been because of their needs. And so I think we need to keep a very wary eye on some of those communities that may well have been avoiding services within that because of the isolation that they've had to have within that. On the deprivation of liberty, perhaps I will pass to Jackie on that. You'll see there are some statistics at the end of the report around the number that have been presenting over the last 3 years within that. So we have reported on that in some detail in the report. But with regards to the particular strategy, maybe Jackie would want to chip in on that.
Yeah, so it's moving away from deprivation of liberty safeguards to liberty protection safeguards. Now, I'm not currently involved in that per se. We do link in through the learning and development subgroup to keep on top of what's happening, and obviously the service manager who covers it for the local authority will bring anything to my attention that we need to be aware of. But as it stands, that's actually on hold until 2023 is my understanding. So the DOLS work continues. There's a lot of work to go for the LPS to come into place.
Okay, thank you.
Hope that answers your question.
Yeah, thank you.
Thank you for your reply. Any further questions, comments on the report? Councillor Smage.
Thank you. I just had a quick question on the report on the cross-cutting safeguarding agendas. You mentioned about 2 domestic abuse officers welcomed into the safeguarding team in 2020, but your next paragraph mentions about the requires a robust system and staff training to meet expected demands. And I just wondered if you had any thoughts on how the panel feel the demand for domestic abuse and other forms of abuse may be in the future.
Chair, if I can respond, if that's okay. It's quite surprising, actually. So the conversations I've been having with some of our colleagues, the police force, we kind of expected to see an increase in the number of domestic violence occurrences during the pandemic. But the number of referrals hasn't gone up as far as we would have expected it to go up within that. Now, whether that's because the nature of domestic violence is, even though you've got more people staying at home, there's more likelihood of it still not being reported, perhaps. So I think there's a further deep dive that we need to do into that to see, because it's just it's not what we expected, and it's quite a surprise. I think what we can take here is some assurance that we are aware of it, and officers and staff in the different services in MARAC are surprised at this. So it is something we're going to pick up and look at further within there. Just generally on a response to that, and the paper talks about looking forward. One of the things that I would hope to be promoting within the new strategy that we'll be developing over the forthcoming year is a much closer alliance with our communities and being able to and support our communities and providing some extra elements into promoting safeguarding across the whole of Kirklees within that. And it's not just because of resources, it's just because this has to be a community response across the partnerships, because of the agencies, the professions, and we work with the community very, very closely within that. It's not just at their eyes and ears. The community provides a scaffolding and safe harbours and a lot of support around safeguarding. And that's something that I'd like to see future work across the partnership, that we'll be trying to do that sort of work. Domestic bit exactly within there, I would thought.
Thank you.
Thank you. Richard, Harry, you have your hand up.
Thank you, Chair. I just want to build the link with the work that's been done on the new domestic abuse strategy. And I think we've previously had conversations as we've done kind of work around raising awareness of safeguarding issues in the past about, does an increase in the number of referrals mean that there are more instances or people feel more confident in reporting arrangements? And so I think with the domestic abuse strategies, a big emphasis on working with perpetrators, so trying to get upstream and reduce overall instances of domestic abuse. But we also have been or continue to do a lot of work around raising awareness and increasing the mechanisms through which people can kind of raise concerns about domestic abuse. So I think as we'll need to keep coming back to the data and asking ourselves what's driving changes in data. Is it about increased instances? Is it about increased awareness? Are some of those preventative activities being successful in kind of reducing the overall number of instances?
Yeah, and can I just mention the domestic abuse strategy comes to management committee for scrutiny next week. Yeah, thank you.
Thank you, Richard. Dave?
Yeah, thanks. I've got a question on the section 42 inquiry. So it's page 36 of your report, page 66 of our pack. You've got a breakdown there, total number of inquiries. And then there's a location of where the risk was identified, and 60% of that is in the care home sector. I just wondered whether there were as an approach of any kind of preventative work in the future, looking at the kind of issues that have cropped up and then trying to put in place strategies to lessen the likelihood of those risks.
Yeah, I think that's exactly the reason that we collect the data, so that we can actually pinpoint it and see where we've actually have some questions to ask and some further investigations to make within that. And that's exactly what's highlighted. I mean, Richard might be able to chip in here as well, but the other part is where we've got most access to people, likelihood to start with any reporting or any identification of issues which would require a section 47. It's more likely to be in those arenas there. But we are always keeping a wary eye on those statistics, and again, that we would do further investigation within that as well. I don't know whether Jackie or Richard want to say anything specific on that.
So I'll come in if that's okay. So as part of our quality and performance subgroup, we actually invite a member and we receive the care home early intervention prevention highlight report, which that team, it's led by the CCG. They work closely in care homes to prevent. So any themes that are trickling through, they'll work with that care home before it reaches safeguarding. So like I say, that's fed into our quality and performance subgroup, so we keep abreast of what's happening in care homes. Hope that answers your question.
Thank you. Yes.
Do you have a supplementary? Okay.
No.
Thank you. Richard, Richard Parry, is there anything further you'd like to add?
No, not at this stage, Chair. Thank you.
Okay. Thank you very much for the information that you've provided us. If I can ask the panel to recommend that we receive the report and acknowledge Rob's extensive experience in ensuring that Kirklees is well placed within his experience around adult safeguarding. I mean, that's quite heartwarming to hear, really. And just to receive the report. Thank you.
Thank you very much.
Thank you, Chair. Thank you, panel.
You're welcome. So if we can move on to the next item, which is the work programme for 2021 and 22. And if I can ask Yolanda to take us through this item.
Yeah, actually, I'll just start with the agenda plan, if I can, on page 79. Just have a look first of all at the next meeting. So 14th of April is our next meeting, which is the financial position of the Kirklees Health and Adult Social Care Economy. So that's now been confirmed. What we're receiving is a presentation where all our partners across the Kirklees area are going to present that to us. We'll also then move on to the review of the work programme. I'm just double checking you can all still hear me. I think I might have lost my connection.
I can hear you.
Can you all still hear me?
Yes.
Yes, it's a bit interrupted.
Good and clear on my side.
Perhaps, Richard, would you be able to just take over the work programme? I'm not sure whether I've got connection. I'm actually, because everybody is frozen on my screen, so I do apologise.
Yeah, I can pick it up. So so as Yolandi says, we've got the two items on the April meeting, the financial position, which has already been summarised to, and the review of the work programme. The review of the work programme is predominantly aimed at obviously looking back over the work of the panel for this municipal year, and to identify areas of work that you feel now have been completed. Obviously to identify any areas of work that you think still need to be carried forward, obviously to next year. Any areas that you feel need to be continued to be monitored, and then potentially to consult on maybe areas or new areas that you want to include for the work programme for 22-23. At this stage, it will just be the panel that will be discussing that. We haven't got any intentions of bringing any other attendees in, but once we've collated the feedback from that discussion, what we will then do is in our first meeting of the new municipal year, we will usually invite comment and input from our health partners and obviously colleagues within the council to help provide you some richer detail around some of the areas that you have highlighted, and indeed to highlight if there are any other emerging issues they feel that you need to be made aware of. That's about it in terms of the agenda plan. I don't know, Habiban, if you wanted to touch upon any of the issues actually within the work programme itself.
Just the fact that we need to add death rates, you know, in one of the future meetings.
Yeah, I mean, yeah, we can do that. I think what we can do is at our next meeting, when we do the review of the work programme, we can include some of those areas that obviously we haven't covered, such as obviously you've talked about the excess deaths data, and also we can pick up on some of the points that were highlighted as part of the discussions around air quality as well today. So yeah, it's absolutely fine. We can all that can all sort of go into those discussions that we have obviously at that next meeting.
Yeah, and we'll have you know, the usual sort of items around the winter pressures and
yeah, that can all be, yeah, absolutely right. Yeah, I think Dave wanted to ask a question.
Yeah, I found the presentation on air pollution very helpful. And I think for future consideration, there are probably one or two areas we'd need to look at further. Interesting just to make the link between the two parts. That's the first item, in that there's a health inequalities aspect to the air pollution information, and perhaps we could be looking at that in a bit more detail. And there was reference made to the public health outcomes framework. I'm not quite sure what that is, but Sean was making reference to that as a kind of context within which this work is carried out and planned. So yeah, I think it'd be useful to have a more detailed discussion later on in sometime in the future. Thanks.
Yeah, that's fine.
Thank you. Councillor Vivian Lees Hamilton, you have
Thanks, However, when they come back with air pollution, I'd like someone quite senior in highways to come back alongside them if we can. A lot of this, you can imagine, with my other job is quite dear to my heart. And it's very important to reduce it. And the best way to reduce it is to get traffic moving. When traffic's moving, it's not so polluting. When it's standing, I'm surprised they haven't got air monitoring in Ravensthorpe, because I really feel for the residents there. It must be appalling. And it's one thing monitoring it, but we need to know what they're going to do about it. And that does come down quite a lot to highways. So I think we need the two in tandem.
Yeah, that I've noted that. I mean, as I say, when we highlight out some of the issues that you will want to include in the forward work programme, we can also start looking more closely at the areas of focus, and obviously we can start to work through where you want the input. And I've made a note, Councillor Lees Hamilton, that you want input from highways in terms to that aspect of air pollution or air quality. So that's fine. Yeah, I've noted it.
Richard.
Any further comments? Okay, that's fine. Richard, are you okay with that?
Absolutely fine. Yeah, that's fine for me.
Yeah, that's fine. And that brings us to the end of today's meeting. I'd like to thank all the panel for their contributions, and to the officers for attending and supporting us this afternoon. And hope to see you at the next meeting. Take care, everybody.
Okay,
Thanks,
thank you.
Thank you all.
Thanks a lot.
Bye.